Alrighty. So when we were talking about today and some stuff that may sort of sometimes feature in the intensive care unit, in a tricky patient in the ICU was one of the sort of things that we kind of briefly bounced ideas back and forth about. I thought about the fact that I've come from a predominantly emergency background, and I went and spent a good bit of time working in the intensive care unit. And one of the patient groups that I found the most alien, that I had struggled to get to grips with most, was the patient with a subarachnoid hemorrhage who's really, really sick. Not just your kind of run-of-the-mill subarachnoid hemorrhage, but the one that's just falling apart. And so in that sense, like we've all seen this patient. So this is a guy who's got a bad headache. He's got a subarachnoid hemorrhage on a CT scan. He's having a bad day, but ultimately he'll probably be fine. It's more this kind of patient, the one who's on multiple vasopressors, the one who's in ICU having a really rough time. All the salts are going all over the place. Blood pressure's through the roof. The heart's given up the ghost. That's the kind of patient cohort that sort of wanted to have a bit of a discussion about today. And we've all seen this patient. They either pitch up in our resus bays, or they're on our neuroanesthesia list, or they're in our intensive care units, or we encounter them in predominantly our inter-hospital transfer in the retrieval sphere. And so I'm going to try and relate this as much as we can to the work that we're doing here in retrieval for these patients. One of the things which I guess it kind of goes without saying is we don't diagnose subarachnoid hemorrhages in the retrieval sphere, but we're often left dealing with the complications of a subarachnoid hemorrhage. And that's really actually, I think, where the complexity can kind of come into its own for us. And so I wanted to focus more on the management of some of the key complications that can happen after a subarachnoid hemorrhage rather than the causes of subarachnoid hemorrhage and talking about aneurysms and silly things like that. Okay. So in view of that, these were the 4 things that I thought might be worthy of discussion, because they were the 4 things that didn't really feature so much in coming from an emergency background, as I say, but that really sort of caused a headache, no pun intended, when I was sort of first trying to learn how to look after these patients beyond the first 4 to 6 hours of their sort of the insult that they were having. So I thought we'd talk a bit about obstructive hydrocephalus. I mean, most people are pretty familiar with obstructive hydrocephalus, but actually the importance of what does it mean for us and what does it mean for our patient. Delayed cerebral ischemia, also known as vasospasm, salt and fluid mayhems, because that can become a real headache. Sorry, I'm going to stop saying that. And ventriculitis, which I didn't even know was a thing until I had a patient with it, and it's, yeah, complicated. So obstructive hydrocephalus, you've got a sealed box, there's some blood in it, causes all sorts of problems when the flow of CSF starts to get blocked, and then the pressure goes up. It's one of the more common complications in a subarachnoid hemorrhage. They estimate around about 30% of cases, which is more than I probably thought, of patients with a subarachnoid hemorrhage get a obstructive hydrocephalus. And it's one of the key causes of the reduced GCS in the patient immediately after the subarachnoid hemorrhage. Unless they've had a seizure or unless they've had a very, very large bleed, we have to really think about the fact that it's probably one of the key causes of the patient actually having a reduced GCS, both in the early and the late phase. But if we don't consider it, and if it's not sort of explicitly reported on by the CT scan, or if we don't even look for the features of it on the CT scan, then we're liable to miss it. But just taking a step back, why does it happen? Well, it's all about flow of CSF, and I think we're fairly familiar with the anatomy of our ventricles and what happens with the CSF as it goes through the brain. But in its simplest terms, blood from the subarachnoid area gets into the ventricles, it blocks the flow and the resorption of CSF, and as a result, it has a kind of a dam-like effect. Pressure kind of fills backwards, and we're all familiar with the Monroe-Kelly doctrine of if you've got more pressure from one part of the system, the others squeeze to compensate until it all decompensates. So ultimately, if we don't address obstructive hydrocephalus, it's liable to cause substantial harm to our patients. So how do we pick this up before it starts to cause irreparable damage? I really enjoyed this photo. So this is a guy apparently had some congenital hydrocephalus and it never really got treated. And then he's got an enormous head, but they're not going to turn up like this. That would be easy. So I guess one of the things that I guess should jump out at us is the patient who's more obtunded than you would expect for the size of the bleed that they've had or how they've initially presented and deteriorated subsequently. That should probably be a bit of a red flag for us. And then also other features of raised intracranial pressure as we're normally used to, our Cushing's reflexes, as storming sort of reflexes, or false localizing signs with oculomotor palsies and the like. We're unlikely to see these patients presenting with the typical ataxia and urinary mischief that you would otherwise get with the different presentation of hydrocephalus. That's not really relevant to this patient group with an acute onset of hydrocephalus. Has anyone seen this eye sign before? Almost. I think that's a dementia-y thing, but it's a very similar. It's called setting sun. Yeah. The setting sun sign. So it's part of a syndrome called Parinaud syndrome. Parinaud was some French ophthalmologist from the 1900s who described a bunch of syndromes when things went wrong with the brain. What's happening here is that the pressure in the cranium is compressing, in particular, the midbrain and the pons, and it's compressing the dorsal aspect of the pons. And what that does is it paralyzes up gaze, it retracts your eyelids, so your eyes look down, your eyelids are a little bit back, but you have this appearance. I didn't know what this was until the first patient I saw it in, who also happened to be the patient who had ventriculitis that we'll talk about a little bit later. But this present in particular in an adult as well was really striking. And at the time, his hydrocephalus had been semi-addressed, but his EBD had got blocked. And so he had hydrocephalus, whilst we all thought his EBD was probably working to fix hydrocephalus. So that was one of the things that really jumped out at me with this eye sign. It's not very sensitive, but if you see it, you see it. And it looks very strange. So what does it look like on a CT scan? I think we've all seen CT scans. There's some subarachnoid blood here, but there's also a couple of features of hydrocephalus. Does anyone want to point out some of the things they see that might suggest there's some hydrocephalus here?
Fourth ventricle looks massive.
Yeah, super.
And the posterior one of the lateral ventricles again look very big.
Yeah, absolutely.
I mean, it's hard to, I guess, without knowing the age of the patient, but the brain is quite full.
Yeah. Those ventricles shouldn't be that size. You're quite right. And there's one that always, I think, is probably one of the more prominent ones. So this one here, the temporal horns, we shouldn't really see those. So that's sort of the really back end of the lateral ventricles as they come round. They're not usually visible. Even in the grossly atrophied brain, they're not usually visible, at least so prominently. And then, as you quite rightly pointed out, the lateral ventricles are enormous, and there's that kind of hazing around it as well, which is a bit prominent. And then the third and the fourth ventricle, which is, as Sam mentioned, are really, really prominent there. So they're the features on a CT scan that should sort of alert you. And the caveat is that the old person with a very atrophied brain can mimic this appearance, but in particular, the third and fourth ventricle shouldn't look quite so prominent, and the temporal horns wouldn't usually be as obvious as well. And also comparing to old imaging in an older patient is probably worthwhile. So why do we care? Why is this important? Is this just going to be something that a neurosurgeon will deal with and then we don't need to think about it? Well, I'd argue that actually we attend to many patients with a subarachnoid hemorrhage, usually in their inter-hospital phase of their care. We're transporting from one centre to another. And usually we're transporting from one centre to another so they can access a higher level of critical care medicine that we can bring to them and continue on later on. And at some point they need to see a neurosurgeon. Someone has to coil an aneurysm. Someone has to sort of ultimately take on their longer term care. But actually, in reality, the patient with obstructive hydrocephalus early in their course, they need a neurosurgeon, then they need an intensive care unit. So actually, we can expedite that process. If we can identify that when we get to a tiny hospital and this patient's got clear signs of hydrocephalus on the CT scan and clinically, that actually taking them to an intensive care unit as the first destination probably is not appropriate. They should go straight to the operating theatre with a neurosurgeon and go back to the intensive care unit, I would argue. And so it's an example of a condition which potentially requires an intervention that we can expedite. So that's why I thought it was potentially worthy of discussion, even though people are probably fairly familiar with obstructive hydrocephalus as an issue. Cool. All right. So thought we'd talk a little bit about delayed cerebral ischemia. I didn't know this was a thing until I spent a while looking after these patients and realized that it just is everywhere. So this is sometimes called vasospasm, although it's a slightly inaccurate term. The proper term for it is delayed cerebral ischemia. Okay. And it means what it sounds like. Okay. Now, when people are doing neurological observations, I've often wondered, like, what does neuro-obs mean when the nurses say they're going to do some neuro-obs? All right, how frequently, what's being checked, who knows? But actually, many a time I've found that the doctor who's in that particular unit, their bacon's been saved by the nursing staff doing regular neurological examinations of the power of the upper and the lower limbs, checking the pupil, making sure that if the patient's awake, the speech remains normal. Because I think that can very easily be skipped in our assessments, and our assessments are usually much less frequent than, say, for instance, an intensive care nursing staff assessment. I think one of the things that we can be really prone to, and I've been guilty of this, is coming to an intubated patient and obviating the need for a neurological examination where they're already sedated. I think that is something that we should probably be checking when we approach these patients first, before we then give a paralytic agent, so that we don't miss issues which can otherwise be underlying under the surface. So delayed cerebral ischemia is, again, another one of these conditions which is surprisingly common. Affects 30% again of people who have a subarachnoid hemorrhage. Again, more than I thought probably was the case. So what is it? Well, this is a bit of a busy slide. I'm not a particular fan of this slide, so we're going to dispose of it in a minute. But I did want to draw your attention to these two things in particular. So on the right-hand side is the pathology that's going on. On the left-hand side is the kind of consequences of what's going on. Vasospasm and brain edema are probably two of the biggest features in this pathology that I wanted to draw the attention to. But the rest of it is just a bit busy, a bit much. Really, we can break this down to someone has a subarachnoid hemorrhage. The aneurysm gets coiled and clipped, okay, so it's definitively dealt with. Then the blood vessels and the brain and the blood-brain barrier start to misbehave. And downstream of that, you get an ischemic stroke. Not rebleeding. It's an ischemic stroke distal to that area because of everything that's going on with that pathology in the brain. And so in that sense, people present with new neurology after their aneurysm has been secured. It can be very subtle, and it doesn't map to your typical stroke syndromes. It doesn't fit into your anterior posterior circulation patterns. It can be minute neurology, but it can have significant implications for the patient. And so you can imagine if the patient's already had a subarachnoid hemorrhage, and then they go on and have essentially an ischemic stroke, that's disastrous for them. So when does it happen? So as I said, it's after an aneurysm has been coiled, typically, okay? In the earlier phase before the aneurysm is coiled, you're much more likely to be dealing with a rebleed than delayed cerebral ischemia. But after the aneurysm is coiled, then you're in this territory where we have to think about this. But technically, it's supposed to be between day 4 and day 14 after the injury. But there's been case reports of it being on day 2 to day 21. And it's very possible that we'll either deal with this issue in the patient that we're escalating to a neurosurgical center, if they've already had a local coiling and they have to go somewhere else for a higher level of care, or in a repatriation after they've had their neurosurgical intervention, they're going back to their local area, ICU, for instance. There's a couple of risk factors that I didn't want to dwell on too much, but suffice to say the risk, the time frame of risk is a bit fluid. So if the aneurysm has been secured, but they're presented with new neurology, this is something that is potentially going to be causing mischief for the patient. So this is where we think potentially we're likely to come into it. The third group, I guess, where we're potentially going to come into contact with this patient cohort is the patient who has had a subarachnoid hemorrhage. They're at a neurosurgical center that doesn't have the higher sort of cardiac support services. So we're not at Vinnie's or RPA that will have a neurosurgeon and things like ECMO capability and stuff like that. But we're at somewhere like Wollongong or at Concord, where they've got an EVD, but then their heart starts to misbehave and they have to go somewhere else for cardiac support, maybe where we're going to come into contact with this patient group. So we know that it's bad. What can we do about it? So I think the key thing is being aware of it, knowing that it exists, but also not skipping over your neurological examination when you first encounter this patient. So I think prior to us deepening sedation and giving a paralytic agent, we need to be able to at least do a basic four-limb assessment of power for these patients. And I think it's very easy for us to skip over that, but I think it should be really a mandatory part of our assessment prior to us engaging with these patients. We could think about prevention as well, and this is going to come into some of the stuff we talk about in a second. If we recall the pathophysiology, the two ones that I wanted to highlight were about vasospasm and were about cerebral edema. Vasospasm, I think we'll all be fairly familiar with nimodipine as a medication. This is what it's for. This is for prevention of vasospasm and delayed cerebral ischemia, and this is why it's important for us to administer it. But it may be that it hasn't been administered so far in the patient's care because they're busy with everything else. So we should be ensuring that these patients have received that level of care. And on the subject of cerebral edema, the targets for these patients is generally euvolemia. And that can get really tricky because they get sick, they get resuscitated with fluid, but then they have, salt and diuresis related mischief, and it can all become a little bit chaotic. So easier said than done, but important to be attentive to. And then if we do find that our patient after a secured aneurysm has got new neurology, what can we then do about that? So the first line of therapy is actually a blood pressure augmentation. We need to increase the patient's blood pressure to perfuse past the impairment, okay, which is quite uncomfortable for a patient with a subarachnoid hemorrhage. So this is probably going to be something to get some early advice on before we do that. And most of the application is initially for fluid and then followed by vasopressor therapy to hypertense a patient and reassess the neurology for improvement. The definitive care for this, though, is with the interventional radiologists, and they need to essentially have intra-arterial use of a calcium channel blocker, nitrates, to try and relieve the vasospasm and the microthrombi that are there. And so this is something that they urgently need to go to a neurointerventional suite for. So identifying it early and changing the trajectory of what you're otherwise doing is going to be really important for these patients. Otherwise, they have an untreated stroke until that gets addressed. Okay. So this can be really, really challenging. Salt mischiefs and fluid status in the subarachnoid hemorrhage patient. And it's often something which, if you ask 3 different people, you'll get 4 different answers. You approach the patient who's got hyponatremia with a subarachnoid hemorrhage, and people sort of pretend that they know what's going on, and then, there's multiple different theories about it, but which one's correct, we're not sure. What I wanted to briefly highlight was the sort of the 4 different things that can probably be facing us with these patients and a pragmatic way to work around them, given the setting in which we'll find them. Okay. And so this guy seems far too interested in the jar of urine for my liking. So there's a condition called cerebral salt wasting, which is really, to my understanding, only seen in the patients with subarachnoid hemorrhage. And basically, for a reason that's a bit unclear still, they lose a ton of sodium into their renal tubules, and a load of fluid follows, and they become profoundly polyuric and hypovolemic. And as we said earlier, that's not ideal for a sick brain. And then we're probably all fairly familiar with SIADH. So they're euvolemic, but they have a low sodium. And then diabetes insipidus, usually craniogenic. So they have a high sodium, but very dilute urine because they're pouring out free water in the urine. And then iatrogenic as well. I mean, it might be that someone's seen a little bit of hyponatremia, thought, I'm going to give them a ton of saline to fix that, and it's got even worse. Or they're giving them some hypertonic, or they're giving them salt tablets, desmopressin, all sorts of stuff. It can be an absolute minefield to sort out. So there's a lot going on. And I'd argue that in our role, with the timeframes in which we are involved with the patients and the timeframes that we need to operate with the patients, if it's not already sorted, I don't think we should be getting lost in the weeds with trying to sort out what ultimately usually takes days, if not weeks, to sort out. Okay. And the renal physicians among you would say, what about the osmolality? Where's the osmolality? How do we work this out without an osmolality? Again, I would say an osmolality for our role is useless. If it hasn't been sent and you don't have the result, then the referring center won't know why the sodium's off. And so you're at square one anyway. If you send it when you get there, it will take about 24 hours before you get a result, and that's not much use to you. If you've got the bandwidth, it might help the receiving center, but I really wouldn't hang any kind of hats on it. In any case, it's probably marred by all of the various treatments that's been given just before you've got there anyway. So I would dispense with interest in osmolality for these patients for our purposes. If you send one and it helps the receiving center, then maybe they can use their wonderful flow chart and sit down for an hour and pick over it and debate it, and then they can sort it out. Okay. Instead, I propose a pragmatic approach to what we can do with these patients in the absence of having 2 hours to sit through this flow chart. So if they have a specific sodium issue, okay, if you get to the patient and they're in intensive care unit and they say, this is a patient with a subarachnoid hemorrhage who also has cerebral salt wasting and their sodium is 134, we're using this treatment, it's getting better, and this is our target. If it makes sense, I think it's reasonable to continue that therapy, okay? But it will take some planning because a lot of this can cause logistical nightmares, especially in a long transfer, thinking somewhere west of Orange into Sydney, 2 hour plus. These patients can have upwards of 800 to 1,000 mils an hour of urine output, and the catheter bag is going to be a logistical problem for you in flight. I know we always empty a catheter before we depart, but I think this is one of these situations where you might actually need a second bag, or you might need to take a bottle with you if you feel like it's not going to fall over. I think I'll take a second bag. You're also potentially liable to run out of fluids if your target is to maintain your euvolemia. And often what they'll do with these patients is they'll match the urine output of the previous hour with the next hour's fluid administration to make sure the patient doesn't become profoundly hypovolemic and also hyponatremic. And so it might be that you need to take a couple of extra bags of fluids from the referring center to keep up with the urine output that you're facing. So really, even if it's working for these patients, there's going to be pre-planning involved. I'm mindful also that if you want to actually prescribe a fluid administration rate, we don't really have the means to do that by air unless we're doing a fixed wing. So we may have to borrow one of those cheeky Agillas. But then if you're the first person to find it, if you're the first person to notice that this patient's urine output last hour was 750 mils and their sodium is 125, then we need to make a note of it. We need to acknowledge what that last urine output is. And in the absence of really the time to sit down and pick this apart, I would argue that the safest thing is for us to match that prior urine output from the previous hour, to maintain euvolemia at least until we get to our receiving center when they have the time and inclination to sit down for hours and pick this apart. The drawback of not doing that is the patient becomes more and more hyponatremic, more and more hypovolemic, and that starts to put them at risk of developing the vasospasm, cerebral edema, the delayed cerebral ischemia that we spoke about before. Okay. If it's a high sodium, then you'd usually want to administer some 5% dextrose with that, but probably getting a phone for help at that point is a good idea. So targets in these patients can be very esoteric. People seem to throw around targets left, right, and center, but usually they're looking for somewhere between a sodium of 140 to 145. I think most of us are familiar with the fact that hyponatremia can leave you prone to cerebral edema, and again features into that pathophysiology we spoke about with delayed cerebral ischemia. And so keeping the patient euvolemic, avoiding hyponatremia, aiming for a sodium of 140 to 145 is kind of the unifying target that they want generally for these salt issues in subarachnoid hemorrhage. Alrighty, nearly there. So this one is, I used to think rare as hen's teeth, and not as much so. So ventriculitis is a weird condition. We don't normally see it very often. This is a kind of condition of people who've got things dangling in their brains and they get infected. Okay. I didn't even know this was a thing until I saw a patient with it, and they get disastrously sick very quickly. And as a result, I think we have to be aware of it as a condition if we're interacting with patients that are prone to it. So how does someone get ventriculitis? Well, they've had a bad day and someone's put a drain in their brain. Okay. So we've got a conduit from the outside world into their ventricle. And I think we're all aware that we've got really detailed BSP that we can refer to with regards to extraventricular drains, EVDs. I would suggest that we're all familiar with that, as I'm sure we need to be. It doesn't specifically make reference to ventriculitis, which is fair enough because there's a lot of other more high priority things with EVDs, but a lot of the key tenets of managing an EVD are in view of preventing things like ventriculitis. So I think that's really good. So in the patient with an EVD, there's a portal between the outside world and their ventricles, not normally there, okay? Bacteria gets in and the patient falls apart, okay? It looks like a really bad meningoencephalitis. Also worth recalling that this is not just limited to the patient with the EVD. This is also relevant to the patient with VP shunts. And they can also occur in patients who've got a shunt that someone has accessed percutaneously with a needle as well. So if someone does a drain of it in their rooms, as I guess a neurosurgeon might do, that's prone to getting infected as well. And it would look almost exactly the same, okay? There's an argument in intensive care that there's two schools of thought as to how to detect ventriculitis. Some people would go with an approach of being a bit of a Puritan, would say if the patient has clinical signs and symptoms that are consistent with ventriculitis that we'll talk about in a minute, then you do a test to confirm it, take some CSF and send it off to a lab. And if that corroborates, then hey presto, you've got your diagnosis. Though there are other schools of thought where there may be a nursing protocol that is that you are to sample CSF every 3 days and send it to the lab. And if the white cell to red cell ratio slightly tips over, then they get all the antibiotics known to man. And the argument then is, well, if you're repeatedly accessing what should be a closed system, are you causing infection? Now, I don't know what the truth of that is, but I'd be mindful of it. The real deal ventriculitis patient is clinically sick and is clinically apparent with those symptoms, but you may get patients who are described as having ventriculitis who just have a slightly dodgy CSF count, and I'm not sure that they're necessarily equivalent. So someone smarter than me can hopefully talk with more definitive answer to that, but I just raise that as a bit of a red flag. So again, how does this relate to us? Why are we talking about this today? I think one of my first jobs was moving a patient with an EVD, and I was fortunately not too unfamiliar with EVDs, but even then, like oh, there we go, we've gone black screen, we're back, okay. I wasn't necessarily intimidated by the concept of an EVD, but what to do with it when we're transporting a patient halfway across a city is a whole different ballgame. So that was quite affronting to me. But then again, we're probably also going to be called to attend to these patients in an escalation phase when they're deteriorating, when they're septic and when they're tachycardic and hypotensive, and it's all going a bit wrong. And I think we have to be really vigilant with these patients that there's an extra source of infection, which is not the norm. It's not the typical chest, abdomen, bit of urine, bit of skin. They've got a tube in their brain. And if we don't do something definitive about that, then actually we can really do our patients a disservice. Because ultimately what needs to happen is that tube needs to come out and the neurosurgeon needs to definitively deal with that, whilst also addressing the fact that they had hydrocephalus, they had a tube for a reason. Okay, so I think the reason why I wanted to highlight this is it could well come up in one of the patients that we're attending to, is febrile and deteriorating, and if we're not aware that ventriculitis is a thing, then we're not going to pick it up and we're not going to treat it. So how do we identify it? Well, really, it's not the most complicated condition. The definition really falls between signs, symptoms, investigations, like most diseases. Most of the time, there's some form of new neurology. It's usually a reduced level of consciousness. It may be something focal if it's formed to an abscess. They might have seizures, or they might complain of a headache if they are awake with an EVD and able to speak to you. Fever is a key part of the diagnosis. And again, the febrile without clear source patient who has an EVD, you've got to really think, is it ventriculitis until proven otherwise? And then again, there's a risk profile for the patient. So it may be in the patient who's got a VP shunt who presents to your ED as well. This is relevant for. Investigations, again, if they are available to us, then that's great. If you're sending them for the first time, then it's not going to help us too much in this role, but I think being aware of it's important. So the patient who repeatedly cultures a coag-negative staph, the con species, like Staph epidermidis and Staph aureus are some of the ones that are really prone to this. Increased white cell count, increased protein, and glucose are all suggestive of bacterial infection in the CSF. But the management is probably the most important thing for us to consider here. We need to obviously maintain our usual standard of resuscitative and supportive care. That doesn't change. But we have to think about the antibiotic coverage and the definitive management of ultimately what is a infected prosthesis, which is that it has to come out, and the antibiotic coverage is usually intravenous, but sometimes actually is given down the drain into the ventricles before removal. So these are things, if you think that the patient's got ventriculitis, some early phone calls with the responsible neurosurgeon to get this definitively dealt with is going to be really important, and may not otherwise be featuring in your sort of default disposition direction that you were taking when you were first called to attend to the patient. So do we think this is going to happen? Are we going to see this? Like, how often does a ventriculitis happen in a patient with an EVD? So I thought it was rare as hen's teeth, but about 10% of EVDs develop ventriculitis. That's not great in my book. Maybe that some of those are that sort of biochemical ventriculitis that you're not too fussed with. But if 10% of EVDs have a probability of getting ventriculitis, I think it's fairly likely we're going to come across one at some point in our path. Now, the mortality of ventriculitis is between 15 and 70%. Very broad range, but probably bad overall. So I wouldn't like us to be complacent. I think being aware of things is an important way to be armed against them. And that's the case, I think, for all four of these things that we've spoken about today: obstructive hydrocephalus, of delayed cerebral ischemia, of the salt mayhems that can happen in the subarachnoid hemorrhage patient, and finally, ventriculitis. That's pretty much all I had to say. Hopefully the next patient we see who's had a subarachnoid hemorrhage, we might think it's not just a subarachnoid hemorrhage, maybe there's something else going on, because I think that's really where we can earn our money. All right. Any questions?